So the purpose of this talk is talking about the point at which you transition your child from pediatric care to adult care. You did this a few years ago.
Just last year, actually.
Just last year you said, yeah. Some of you have really little kids, some of you have teenagers, but the idea is getting ready for that adjustment or that transition, as well as a few more words based on Elaine's foundation in terms of compliance with medications. So transitioning is defined as a purposeful, planned movement of adolescents and young adults from child-centered to adult-centered care. So it means we don't wait till they're like 27. We don't do it with no planning. We don't do it without a thoughtful integration of the child's needs and what the system can offer and so forth. So it's planning it out. A lot of people that do a lot of work in the area of transition say you should start talking about it about age 12. It says that groups like ours should have a policy that says, you know, we only take care of you till X age. And of course, X age is going to depend on the kid and on a lot of things. My patients, I'll say, you know, if you want, I'll take care of you 1 year into college. Because that's a very transitional, lots of things happen that year. But after that, you're probably better off with us finding an adult liver specialist or an adult GI specialist. So having a policy and then starting to talk about it and then doing conscious, thoughtful, intentional preparation. And then the actual process, it's seen here under 18 to 22, is transferring care. So transition is this whole process of getting the kid ready and the family ready. Transfer is when the actual transfer of responsibility, nice and clean, with adequate information and adequate follow-up takes place. So the people that research this a lot, and there's a really great website called gottransition.org, and gottransition.org has stuff for doctors and stuff for families and stuff for schools and some tools you can use. So they talk about the policy, a way of tracking that we as institutions should have a system where we make sure we're doing the right thing for everybody, that we assess readiness of the teenager or young adult to transition to adult care, that we plan it carefully, have a package to transfer, and then assess completion. So, you know, for the patients that are in the room, it's interesting to reflect, how important is it to you to transition? Do you even care about it? Do you think it's important? When do you think it should happen? And how confident are you? And you talked about empowering the kid and giving them enough responsibility and enough tasks. And so how ready is that kid for transition? So some of the things, there's a bunch of tools available that I think are quite useful. Do you actually know what your condition is, and can you explain it to somebody else? And sometimes in the office, I'll say to the 13-year-old or the 16-year-old, if you have to explain it to a new teacher or to a new acquaintance or a friend, how do you explain your condition? It's really interesting that sometimes we don't give people the words or the tools to explain. Do you know what symptoms? Let's say you have colitis. Do you know what a flare looks like for you? Is it stomach aches? Is it bloody diarrhea? In autoimmune hepatitis, it's harder because there are so often not symptoms. But do you have symptoms when your enzymes are high? Or is that a way to reinforce, gosh, you better go for your blood work because you don't have symptoms? What to do in case of emergencies. If you're immunosuppressed, a fever is a big deal. And I want the kid to know what kind of a fever is a big deal and what's the action. Do they know to tell their mom? Do they know to tell the pediatrician? Do they know to call my office? Allergies. Some of our patients, for example, should not be taking Motrin. Patients with colitis, it can irritate the colon. Patients that are on transplant medications, it's bad for the kidneys. So they need to know what medications they are not allowed to take and what medications they're actually allergic to. I'm going to talk a little more in a minute about important health information to carry around. There are privacy issues that the teenager going to adulthood needs to know about. And then the child may need to explain their own history. You know, I'm a vegetarian, I don't eat meat. This is how I get protein in my diet, and this is how I get iron, and so forth. So that there are social issues as well. Using health care, so at what point is the child in charge of prescription refills? At what point is the child in charge of appointments? At what point does the child maintain a calendar? At what point do referrals come into, a question of when I need another doctor, how do I get that referral? The whole insurance the whole insurance thing and so forth. So all these you have to kind of think through, and you can't work on all these at once. It's very overwhelming, but rather one at a time and pick one to focus on, get ready with that one, and then focus on the next one. Parent readiness is also an issue. Many of you, your kids have been diagnosed when they were 2-year-olds or 4 or 6-year-olds. And to be ready to make that transition, you trust the pediatric subspecialist so much that made the diagnosis and followed you through all these years. How do you get ready to trust another doctor? And it's going to be a different system. The adult world is a little different from the pediatric world. And maybe if you guys get a chance to speak up afterward or during, some of you can talk about your experiences, but getting the child ready to trust another specialist and be in charge. So again, the adult has to assess, if we talked about privacy, if you call our office after age 18, technically our office shouldn't talk to you as a parent unless you had your teenager sign a form that enables us to speak with you and specifies what we can say. So anticipating that and getting everything ready is quite important. The fact that you can see the doctor alone when you're over 18, and I think we don't do as much as we could with that whole privacy issue. So I think there's a lot of privacy issues that need to be thought out ahead of time. Think about some of these things like coming to the visit 15 minutes ahead, that you might lose your appointment if you're 15 minutes late. All the forms, all the things about prescription refills and the timing of those. So there's a lot of things to getting the teenager or young adult ready. It's a neat idea to make a plan and to ask. It needs to be patient-centered, family-centered, but also patient-centered. So, what matters to you as you transition to adulthood? For a lot of kids, it's autonomy. For a lot of them, it's being safe. For a lot of them, it's having their support system there. What do you need to learn to be able to run the show? And it's really hard to think about those things. So making goals, making a list of actions, and kind of assessing that those happen is a good idea. And just an idea of some goals. One would be to have a sense of what is healthy for me. What are my goals for being healthy? Is it being on the least amount of prednisone or no prednisone? Is it taking my meds every day and having good labs? Is it having no diarrhea? What symptoms, what counts for healthy for me? Maybe the goal for the kid is reading about your condition and really understanding why you take. I don't know how people take medications that don't understand why they're taking them. And so making sure that knowledge is there is important, particularly when people are asymptomatic, as they often are with autoimmune hepatitis. A lot of my liver transplant kids were transplanted when they were a year old. They don't remember feeling bad. And so to keep on taking that medication is tough, especially in the teenage years. Learning about the medications and what they do, doing most of the talking at the visits. I can sometimes have a 9-year-old patient and do the whole history with the 9-year-old patient. It's so interesting how different people are. And I can sometimes have a 15-year-old that I can't get to talk. So it's incrementally doing more and more of the talking at visits and bringing questions to empower the teenager for it to be their appointment. So this can all be thought about and planned, but in little bitty steps. Things that you might ask your doc is, what do I need to know? Do you have some kind of tool I can use? And there are a bunch of tools online. The guttransitions.org has a bunch of links. I'm going to talk in a minute about a medical summary. It's nice if you go to the next doctor or to your emergency room with a list that says, this is what's wrong, these are the medications I take, these are the issues that I have. And so we'll talk in a minute about creating that medical summary, which is mostly your doctor's responsibility, but you can be activated to participate in that. Again, the privacy and consent things when you turn 18. The teenager needs to know about when this transition thing will happen. And maybe a list of doctors. The idea is I'm not going to just dump you. You are going to go to a doctor who I help you pick, who's reasonably convenient and expert in your condition. The teenager should probably have some papers in mind. A lot of this is obvious. Of course, you have your driver's license around, but how many teenagers carry their health insurance card, have their doctor's phone number, know how to communicate with the office and negotiate the layers of people that you have to talk to? The calendar, as the teenager becomes older and older, the calendar of appointments, blood draws, and so forth are important. The medication list. And then maybe in a list of records at home, immunizations are important. You know, you're about to, let's say you're looking in the future at liver transplant, or you're on immunosuppressive medicine, so you haven't had your chickenpox shot, or you haven't been able to get your measles shot, depending on when you were diagnosed. And so this record of immunizations is quite important, as well as information about your doctors and about your medications. So your doctor could help you get ready for this. A letter of introduction would be lovely. The letter says this is what the patient has as a primary diagnosis. It's autoimmune hepatitis, accompanied by overlap with primary sclerosing cholangitis and ulcerative colitis or Crohn's disease. We also have been having blood pressure issues, or someone mentioned cataracts and so forth. So all these can be listed, kind of a background, and then offering to help during the transition period. So this letter of introduction could accompany your transfer packet. The next couple slides are about a portable medical summary and an emergency care plan. So contact information is key, and that might be the teenager's cell phone, email, and so forth, and it might be the parent's email and cell phone. Emergency contacts, prefer location for emergency care, assuming it's not a terrible life-threatening emergency. Do you want to go to your pediatric hospital? Have you decided which things can be managed at the local hospital? It's kind of nice if there's certain kind of emergencies you've tended to have a list of those and how they were managed, as well as allergies, drugs, things to avoid. The diagnoses have to be clear, the medications have to be clear in terms of dose, dosing interval, and so forth. A list of healthcare providers. This medical summary that you help your doctor to prepare would have a list of surgeries, might have a list of procedures. For example, in autoimmune hepatitis, it's kind of useful to know my first liver biopsy showed cirrhosis. I had a follow-up liver biopsy 5 years after my first, and it was completely, maybe not after cirrhosis, but after active autoimmune hepatitis. Maybe the next biopsy was normal, and that's why we wean meds. That's kind of a useful thing to know and to track. Most recent labs and x-rays. When did you have that ultrasound Dr. Rao talked about? How often are you doing your labs? Equipment's not really going to be relevant mostly for you guys. School and social information, and then just special information that you want your doctor to know. You know, it helps me if you use simple language where I'm not spinning my wheels trying to understand the words you're using. Or, you know, I want to know everything. Don't be afraid to tell me everything. You can guide your next provider by explaining what your needs are. I found this on, I think this was on the gottransition.org website too. It had a neat lexicon of terms that we all know that I don't think necessarily the kids know. What's a deductible? What's a copayment? What's a premium, and importantly, what's in-network and out-of-network. If we don't educate and orient our old teenagers, young adults, they won't know how to maximally use their insurance policy to protect themselves from financial harm. Yeah, so some of the language and some of the policy stuff, it's so boring, but there's at least a good part of it that they're going to need to know. This part is for the teenager. So this goes more, again, about the health insurance thing and copays on prescriptions, maybe the use of some coupons that are available online, the parts that you have to pay and so forth. These are things that the teenager or young adult is going to need to know. Self-care things for the teenager. I think among this list, taking charge as you age, and it'll be interesting to hear from you more in terms of when did you take charge of your every 12-hour meds? When do you start calling for refills? When you run out, it's a big giant deal, especially if you're on transplant meds or if you're on seizure meds or if your condition requires constant immunosuppression. Using a calendar is a very nice habit to develop early, and the kids seem to have a phone from age 6. So, sticking that appointment on the calendar, sticking that reminder for labs, using calendar reminders, having the insurance card, knowing how to call the pharmacy, and knowing the names of the conditions, because your kid isn't always going to be with you. For the point of transition, the issue that the child, who's not a child anymore, is in charge starting age 18. But you guys get to craft what that looks like. Are you allowed to talk to the doctor? Are you helping? Do you graduate responsibility over time? But if you don't get ready, then when they go to college their freshman year, it's really hard to combat all the things at once. Take your meds, eat some vegetables, don't drink too much, don't drink at all, depending on what advice you've been told and so forth. And so preparing for it ahead of time is very useful. Decision making is quite interesting, and I want to emphasize here that if the child has disabilities, you can and should, intellectual disabilities, get legal guardianship at age 18, so you really can sign, and you don't find yourself without the tools you need to help your child. Otherwise, have at least permission to talk with the healthcare team if your child wants you to, help the child learn enough about the condition to figure out what they need to do to make their own decisions. The career planning stuff is kind of interesting in terms of having it in your head, you have a chronic disease, you need to remain continuously insured, as you said. And that's going to mean making sure you have a job with benefits, a job that comes with insurance, and that you understand the parameters of that insurance, and that you understand what it needs to take care of your condition. Disclosure is an interesting point. Who do the kids have to take and tell in terms of their medical condition? And you've probably already faced that. Did you tell the teacher? Did you tell the school nurse? Did you tell just everybody? And that decision is within your control and requires some thought. And then the teenager or young adult will have to think about that too. When you go to a party, do you say, I have a liver problem, I don't drink alcohol? Or do you just take a drink with a lime in, a fizzy soda with a lime in it, and it looks like a drink, and you don't tell anybody? But these are things to be thought about. One point that I won't read you guys all the stuff on the slides, but salary and benefits and making sure that the job comes with insurance, especially if it's not full-time. So a lot of these are going to take thoughtful analysis as the teenager ages to make sure that insurability and health insurance covers. So just to summarize the transition portion, again, start thinking about it early, and hopefully your institution has a policy. Track progress with your child, talk about little things, then build them up, and be thoughtful about what they need to do to be ready. Prepare for the transition, will help you provide documents to the doctor you transition to and help smooth that transition. It's an adjustment because everybody's style is different, and the style in adult medicine is different from pediatric medicine. So thinking about the steps and doing the best you can to be ready for it. I'm going to change gears for just a moment, but I'm going to leave time for discussion. So adherence or compliance is taking your medicines like you're supposed to. Actually, compliance is thought to be a more passive term, and adherence is sort of like you're more in charge of the process. So you can use either word. Most people use adherence these days. 50% of people don't take their meds as prescribed. The responsibility is not just the patient's. We as a medical team need to make sure that it's possible for the patient to take all their meds. Adherence can have a very important effect on health, maybe more important than which drug is chosen by the doctor, is that the drug is chosen every day. It's hard to identify when patients are not adherent, especially if you don't ask the right questions. I remember, it's got to be like 20 years ago, I had a liver transplant patient that I saw regularly for years before I found out that he wasn't taking any of his transplant meds until the night before the visit with me at midnight. And that meant that when we got a level the next day, there was a measurable level. That kid wasn't getting any medicine for a long time, and I didn't figure it out. There are some solutions that can help. So why are people non-adherent? Sometimes the patient doesn't understand their condition. They don't know why they need it. They perceive that they are asymptomatic, therefore why take medication? Or they might not be motivated. It might be medication. Maybe I gave you too many medicines, and maybe I gave you 5 medicines and 2 were avoidable. Or maybe I dosed it 3 times. Nobody takes medicines 3 times a day, like ever. And so maybe it's a question of dosing frequency. Maybe we made changes too often, or maybe there were side effects that you didn't know to tell me about. Sometimes depression or symptoms prevent people taking their meds. Sometimes it's the system and what their insurance covers and the wait time at the pharmacy, and they didn't have a 90-day versus a 30-day and so forth. And sometimes it's just the whole environment that it just makes it so hard. If you don't have a car, if you don't understand how to get the script done, you may not have continuous medication coverage. Solutions, it's important to not assess blame. We are all responsible for people taking their meds. Understanding each medicine and why you take it, I think, is vital, and eliminating medicines that are not vital. Us checking how the patient understands the need for the drugs. Less frequent dosing, keeping the regimen as simple as possible. Cell phones and watches are great for alarms, and the alarms empower the youth to have an active role in taking medications. Pill boxes that challenge you to make sure the pill box is empty each day of the week, sometimes 2 pill boxes for morning and afternoon meds. Some people whose insurances let them, 90-day scripts help because they don't run out. And sometimes there's coupons or workarounds or a cheaper drug, but we all have to communicate. Questions we could ask. It must be hard to take all these meds. How often do you miss them? I've learned not to say, are you taking all your meds? Because they always say yes. But if I say, how many times a week do you miss your cyclosporin or your azathioprine? Sometimes I hear 3. So, or specifically this medication, how often do you not take it? When's the last time you did take it? Have you ever had to stop any of your meds? And are you having any side effects? That's one I haven't been asking that I will, because maybe there's side effects that cause non-adherence that I don't know about. So I want to open up for discussion. In summary, as your children approach teenage life, make a plan for what needs to be learned and done to get them ready for taking charge of their own health care. And every kid's going to be different as to when they're ready. Regarding medications, reflect on adherence and how that can be improved. What's the main reason you don't take your twice-a-day meds 14 times a week? And think out why and get around those obstacles. And then these are just a couple resources, gottransitions.org and scriptyourfuture.org for medications that have some suggestions, some checklists, and so forth. So anybody that just wants to share their experience or ask a question, I think all 3 of us would be eager to hear you or to answer questions. Yes?
Okay, I got 2 questions that I wrote up yesterday. One is, so my daughter was diagnosed last week with photosynthesis sensitivity, and they think it might be linked to either her medication or her disease in general. Is that something you guys see often?
So in other words, does she sunburn easily and get real red and stuff?
No, she actually like fully rashes, her body swells, she runs a fever.
Wow.
Yeah, so we're in the process of getting so she has a hematologist in 3 states. She has a GI specialist, a rheumatologist now, dermatologist, and an allergist. So we're in the process right now of doing skin biopsies and allergy testing, but they didn't know if that maybe it also just went along with her medication and they couldn't prove or not prove.
Is she on any sulfa drugs?
No, we're only on our Imuran, our vitamin D, and then we just got off everything else.
those aren't classic for photosensitivity, those medications. So that's why they're looking at other things, I think.
Okay, okay. Cool.
You had another question.
Oh yeah, is there any stem cell research that has been done for
autoimmune? I don't. Go ahead.
I know someone who, not in the States, but I think it's Panama, but he was saving up money to go down there and try it, but he said that he's like one of the first ones, so there isn't really that I know of, at least, but he's looked into it extensively.
The problem with, what would you stem cell? You wouldn't necessarily stem cell liver stem cells. It would be more the immune system that's attacking the liver. It's complicated to think through, right? Is it the victim, which is the liver, or is it the immune system that's attacking the liver, or is it some combination of those two things?
The only thing closest I can relate to patients with colitis, Crohn's. In a small number, people have done bone marrow transplants, with the idea being unrelated to transplant, replacing your own system with a different system which doesn't attack your own body.
But Girish, didn't those patients need the bone marrow transplant for another disease like leukemia? And the Crohn's got cured for free.
So this is completely like by the way. So for autoimmune, I'm not aware of any.
I'm not either.
Yeah, okay.
Questions or comments?
I think, my question might be lame, but probably all of you. This has been very interesting to me, all three of you. I mentioned that, Gavin has been a long-term user of prednisone and stuff like that, and has had a lot of other problems, like he has cataracts, and he has bone density problems, and he has really short stature. Because of all those things, people babyfy him.
Yeah.
Strangers chuck his cheeks, isn't he cute? And I'm like, I hope you think that in a couple of years when he's getting facial hair. And his mom and dad, and I was just writing a little note to Leanne, like, we need to put a step stool so that he can access the plates and glasses and so, because he's 11 and he's like
that's
a
cool.
little emperor. And we're like, waiting on him hand and foot. He had a meltdown the other day when his mom wouldn't his mom did let him sleep with him, and then mean old grandma said, "You're 11. You cannot keep sleeping with your mom." But those I think are very real issues, and I think some of it's because he's quote unquote sick, and so they just treat him differently. His teachers do. He gets out, he gets away with stuff in class. He misses class, and it's not a real healthy cycle.
Sure.
And I wondered what you guys have to say. I wasn't not listening to you. I was Googling normal developmental stages for an 11-year-old.
So that's often what I'll do.
That's
And
wonderful.
I'll have people do, I have a handout that actually has it compared. So typical teen or preteen roles and what their expectations are versus your own. And I have both the patient and the parents fill it out. And then talk through what are ways that you can increase your responsibility and your independence in those roles. Because I think that happens often. And it's kind of a snowball or slippery slope, right? Because you want to take care of them, you want to safeguard them and protect them. But by doing that, we also disjoint them from what typical kids are doing at those developmental milestones. And so we want them to reach similar milestones at the same trajectory. Having a chronic medical condition does not inhibit them sleeping in their own bed or them, being able to pour their own glass of milk or things of that nature.
Right.
And so starting slow, but really I would almost have the parents sit down and have a discussion about what are they doing and what could they be doing.
Make it almost a joint
Yeah.
decision.
Well, I'm going to use all of you as
I have a little patient that I adore who, she is a little person. So her condition, she's 17, and she's like this tall. And the minute she opens her mouth, she's 17. But you have to really, make sure to treat her like a grown-up. And you forget for a moment because she's so little. So
We had someone give us like really good advice, and they said that like we need to remember that Kayla is Kayla that happens to have autoimmune hepatitis. She's not. This is my daughter who has autoimmune hepatitis, and her name is Kayla. Like she needs to be that first.
yeah, the Cystic Fibrosis Foundation has made a big deal of that. You can't say she's a CF patient. You say
Exactly.
she is a person with
Exactly.
CF.
Because especially once they get so many things stacked on top of each other, because Kayla lives a good chunk of her life in the hospital. I mean, a lot of her life in the hospital, and it's not managed well. But if we let that kind of overshadow everything else, then before we know it, our 5-year-old is standing there picking up all the toys, and our 2-year-old sitting there going, "Well, I just got out of the hospital." Like that's not fair, and that's going to create a life that's challenging for both.
Well, if you have resources for us, I mean, obviously we would love support group kinds of things too. We're in enough, and maybe even at some of these conferences, if we could start bringing some of the kids and having a track for them. Gavin went to the one in Cincinnati, and he was hoping to meet other kids like him. And what he meant by that, I think, was other kids that are short and are bullied and are explaining themselves all the time.
There's a network at Riley. We do have a liver support group at Riley, but it only meets once a year right now. And then we do kind of a organ system pediatric GI day. But there is a chronic diseases where you might get more people and they might have different stature depending on what's wrong that the hospital has. And I'm blocking on the name, and maybe I'll take your name before you leave. I simply can't remember the name of it.
Anyhow, but this is helpful.
Yeah, it might be worth asking your hospital. Yes.
There's this app called Liver Space, and it's specifically for pediatric liver disease.
Liver space.
Liver Space, yeah, and it also has this feature where you can like set it up to like meet patients in your area and stuff, in like a targeted geographical area. So I know that they even have like, it's geared towards like the pediatric patients themselves instead of the parents. The parents can also, and caregivers, grandparents can also be on there too. But that's a really nice app too. And then there are like Facebook groups and stuff too. So maybe you could get on there and ask the parents, hey, are any of your children like suffering with this? Maybe they could even be pen pals or something like that. Even if they don't get to meet face to face, and they can write that out, because writing is very therapeutic too.
The other physician group that has the most experience with kids with short stature is pediatric endocrinology. The kids that have growth disorders maybe more, less than the usual height expected for age.
Right, he is on growth hormones now.
Yeah, so that might be a good question for the endocrinologist that prescribes the growth hormone. You had a question?
Just a couple comments. Thank you all so much. I learned a lot, and I wanted to share a couple things. One is I would love to see a little bit of talk about the effects of chronic disease on siblings, and how we as parents, can help our other children through that, because that's been a real big issue for our family. What's that?
Juggling.
Yeah, and just, we're so hyper-focused on this one child. We know what happens when that happens, and the effect it has on other kids. I also want to share a little bit about, since we are in that transition stage right now, and it's been a lot more challenging than I thought. We're doing fine, but it's definitely been a challenge. I didn't think it was going to be this way. And we started, maybe not at 12, but we probably started at 15. I think.
That's impressive.
Yeah, I think his doctor's been really great about, and I would be noticing that we'd be going into appointments, and his doctor would not be looking at me. And I'm like, okay, I can take a hint. I gotta be quiet here. But yeah, that was sort of how it all started, and then, the filling the pillbox thing, when I stopped doing that, I don't know why, but transition-wise, that was one of the hardest things for me, is to not fill that pillbox.
Yes.
Because control probably, but also I feel like I can't do much for him. So that was just something that I knew I could do. And that was, so when I stopped doing that, I don't know, it was like, my husband was like, why do you keep doing that stuff? But anyway, so that was a big step for us. But one of the things that I really underestimated when he went to college was nutrition.
Mm-hmm.
We went through the whole pill box, how to fill prescriptions. He does all that. Now when he wants me to help him with it, I'm like annoyed. Like, you can do all this on your own. So, but nutrition has been a problem. He's not getting home meals, he's not getting breakfast, and he's lost weight. And we know when you're barely surviving with your weight, like staying in the normal range, can make a big impact.
And the concept of food as a medicine, when you already have to take meds, is a hard one. You almost have to, for him, he has to prescribe meals and snacks
Yeah.
as part of his medical regimen rather than as
Well, that's
something
where we
optional.
are a little bit.
Yeah.
We're realizing that is how it has to. But that's a whole mind switch in a way.
It is, and it's asking him to do another thing.
It is.
And giving him some choice may help too. Like if he really hates eating breakfast, do you like hot fudge sundaes? I know that sounds just terrible,
Right, no,
but I'm not above thinking of solutions that work for you. And if it's peanut butter and crackers, peanut butter is a good source of protein. Ice cream's not bad for calcium and protein. So, having him choose, within reason, choose some things may help too, but again, to consider it part of his regimen.
Yeah. That's really excellent points making it part of the medication.
But you're right, it's very hard. Sir?
Chris is right. There should be more emphasis on family dynamics because it affects the whole family, this disorder. And we're grandparents. And we have a non-compliant mother.
Oh, that's hard. That's
And,
hard.
And also Gavin has learned about free passes. He's using this disorder to get free passes. Sleep with the mom. Oh, we gotta eat sushi because I'm sick. This is what I want. Boom. We're caught in the fishnet. So the dynamics is really powerful. I mean, how do you control this? And we want normalcy.
And it sounds great that you have therapy, right, it sounds like, as part of the team. We see an endocrinologist locally and the gastrology department is a children's, and so there's no real team approach going on. And so it makes therapy seem like
Yeah, and there's a stigma there, right?
there's a stigma that there wouldn't be if it was part of this is what happens. Maybe we should ask when we're taking to children next thing we
Yeah, they have those resources there.
Yeah,
And they can bring them in.
yeah.
The problem is the distance for we're so lucky to have Elaine and when she sees people, you see people often every couple of weeks when you're doing intensive therapy, and if people live 3 hours away, she often suggests to them resources closer to their home, but you're right, it's very dicey. It's a real defect in our system.
So there are
Good
movements for
question.
telepsych, and some children's hospitals are doing that. And so telepsych is like a similar format to a Skype or a FaceTime.
So you're saying tell us psych?
Yeah, TELE and then psych.
Okay.
And so that's something to ask is whether the hospital has that. It just involves a lot of technology and a lot of kind of insurance and resource acquisition, but some hospitals are very insurers.
What other questions or yes?
So our son Alex, he was diagnosed when he was 10 months old. When he was doing that, he didn't get a lot of his immunizations, and was provided Adherence, prednisone, and at some point he came off of his prednisone. Enough time passed where they said, well, we can give the non-live vaccinations.
Yes.
And he had them, and then 3 months later he started to get a flare-up, but at that point they were actually saying that we can give him the live vaccinations while he's on Imuran. And I know when you read the Imuran labeling,
Yeah.
it says do not do that. And they said that they have done it and that they sometimes will react a tiny bit but not much. What are your feelings on that?
We-
Well, like our central policy, we don't, but there are centers which are pushing to get live vaccines in patients who are not severely immunosuppressed. So it's monotherapy is ignorant, so they are doing it. So there is, I think, data which they always.
Kirish, you've done it haven't you done it once or twice? I've done it only once or twice, but there are centers that are studying it.
Very center specific, but for example, like our transplant population, we never give it. But there are centers which are kind of saying, you know what, that never, maybe it's not be never, maybe they're, especially in infant, right? If you have somebody who is 10 months, they're missing a slew of vaccines because they're all vaccines. So I think it's center dependent. I think there is data to support, at least there's some coming to say, I think it's not deadly, it's not going to make them really sick. I think it's safe to do it, but it's somewhat center dependent. So indeed, we are not doing it, almost by default.
Okay.
But again, if some center does it, I think that's probably a reason, and if they have experience and there's data, I think probably something to discuss.
Yeah. Y'all understand the reason, right? It would be that they could get a form of measles that their body couldn't fight. That's the one I worry about most is measles.
Yeah, that's what they say, that they even have all their transplant patients get the vaccinations. They say sometimes they will get a little reaction at the site of the.
Who cares about that?
vaccination,
But they're doing measles on other transplant patients? That's
Yeah.
I don't know
awesome.
if it's transplant, but they said
Well, they
that
said they
for
require
Awesome.
all the
his condition
transplants.
specifically, they said that they.
Because Imuran's not a ton of, but like you said, the party line and the labeling of the drug is don't give vaccines.
Exactly, and it's in like bold
But
letters.
It is.
That's
It's like
what
the
scares
risk
me,
of
you know?
actually not being vaccinated and getting the actual, sickness, whether it's, measles or mumps or whatever,
Yeah.
is worse than whatever they might get if they get the vaccination.
Yeah, so hopefully people will publish. I think a couple centers are studying now. Hopefully we'll know like an actual answer to that. You'd have to do a lot of vaccines though, because the badness is not common. Bad side effects are actually not going to be that often. So you couldn't just study 20 people. You'd have to study a lot. All right, any last questions?